Welcome to Talking Ketamine, episode 20. Imagine navigating two of life's toughest battles at the same time. You've got the crushing weight of depression and, well, the relentless grip of opioid addiction.
It's a reality for millions, a really difficult reality.
Exactly. And today we're exploring a pretty groundbreaking study, actually. It offers a surprising new perspective on how we might tackle this dual challenge.
Yeah, it's a really interesting piece of research.
Our focus for this discussion is a truly insightful paper. The title is Adjunctive Ketamine versus Buprenorphine in Co-occurring Major Depressive Disorder and Opioid Use Disorder. Quite a mouthful, but it's basically looking at anxiety and craving.
Right. Published by Mansouri and colleagues in Trials just this year, 2025.
And it really sheds light on how ketamine, the compound generating all this buzz, compares to buprenorphine. Buprenorphine being, well, a cornerstone of addiction treatment.
A very established treatment.
And how they stack up helping people with this very challenging dual diagnosis. So why are these two, wildly different compounds? One's an anesthetic, the other's basically an opioid medication. Why are they being pitted against each other for mental health?
Well, it really speaks to the desperate need for new solutions, especially in dual diagnoses. It's just so complex.
Right. And this study, it offers, a surprising piece of the puzzle. Let's unpack this.
Okay. So what's truly fascinating here isn't just the scale of each problem on its own. Major depressive disorder, MDD, affects, around 264 million people globally?
Huge numbers, a leading cause of disability.
Exactly. And then you have opioid use disorder, OUD, that impacts about 16 million individuals worldwide, contributing to massive health crises, mortality.
Right.
It's staggering.
Yeah, those numbers alone are just sobering.
But the really formidable challenge, and this is the precise focus of this study, is how often they happen together. They co-occur.
Right.
Imagine trying to treat severe depression when someone is also battling intense opioid addiction, or, the other way around.
It must make treatment incredibly difficult.
It does. Studies show a clear bidirectional risk. So people with MDD are more likely to develop OUD, and people with OUD often develop MDD.
A vicious cycle.
Completely.
Yeah.
And this comorbidity makes treatment so hard because, traditional depression treatments like SSRIs, they might be less effective, or you might worry about drug interactions if OUD is present.
Okay.
And then on the flip side, the medications used for OUD, they often don't really tackle the deep symptoms of depression adequately.
So you're stuck. It's like this tangled knot.
It's a perfect description.
Yeah.
A complex, intertwined knot that desperately needs new ways to untangle it.
You mentioned that knot of MDD and OUD, and often there's another thread tangled in there too, right?
Yeah.
Anxiety, where does that fit in? It feels like more than just a side issue.
Absolutely. It's not just a side issue at all. The co-occurrence of anxiety and MDD is, it's almost the norm for many people.
Really?
Yeah, the National Institute of Mental Health estimates something like 60% of individuals with MDD also have an anxiety disorder.
Wow, 60%.
And maybe 40% of those with anxiety also have MDD. So they're very closely linked.
Okay.
And this means anxiety symptoms,
Yeah.
The excessive worry, restlessness, irritability, they can significantly worsen opioid cravings and withdrawal.
Ah, that makes sense. If you're already anxious.
If you're feeling intensely anxious, intensely distressed, that can easily trigger or ramp up the urge to use opioids, maybe as a coping mechanism, even a desperate one.
Right.
So addressing anxiety isn't just, a secondary goal. It's critical. It affects the depression. It affects the addiction. It often fuels that vicious cycle we mentioned. Research even suggests that both anxiety and MDD are linked to abnormalities in brain regions involved in emotional regulation, like the amygdala, the prefrontal cortex, which just highlights how deeply connected they are biologically, too.
Okay, so given this really complex picture, this research looks at two adjunctive therapies, meaning they're used alongside standard treatments. Yeah.
That's right. Added on top of the usual care.
Got it. So let's start with ketamine. It's in the news so much these days for mental health. What makes it seem like a good candidate for these co-occurring conditions?
Well, ketamine, which traditionally, as you know, is a dissociative anesthetic,
Right.
it's gained significant attention for its incredibly rapid antidepressant effects. I mean, really fast.
Faster than typical antidepressants.
Much faster. It's shown promise even in treatment-resistant depression or for acute suicidal thoughts. It can offer relief much, much quicker.
That's huge.
It is. And this study specifically looked at its adjunctive use. So given alongside the standard psychiatric and addiction treatments, not as a replacement.
Okay. And how does it work? What's the thinking behind it?
Well, this is where it gets really interesting and different from older drugs. It's thought to work, at least partly, by affecting the N-methyl D-aspartate receptor, the NMDA receptor.
Okay.
Think of it less like just tweaking chemical levels,
Yeah.
like SSRIs do,
Yeah.
and more like helping the brain build new, maybe healthier circuits.
Oh, like rewiring.
Sort of, yeah. It encourages what scientists call synaptic plasticity and neurogenesis, basically new connections and growth in key brain areas for mood, like the prefrontal cortex, the hippocampus.
So it's almost like it's helping the brain literally build new, healthier pathways, not just adjusting chemicals. That's a powerful idea, like a quick brain reboot.
Precisely. That's a
Yeah.
great way to put it. And that neurobiological effect might also reduce anxiety symptoms by changing how glutamate, the brain's main excitatory chemical, works.
Mm-hmm.
So when ketamine affects those NMDA receptors, it's believed to kick off this whole cascade cellular mechanisms that boost something called BDNF, brain-derived neurotrophic factor.
Often called brain fertilizer, right?
Exactly. Good analogy. And this encourages rapid synapse growth, better connections in those crucial emotional regulation areas. So the brain isn't just getting a temporary lift, it's actually fostering growth, almost helping it heal and adapt.
So what did the study actually show about ketamine's impact? In this specific group, MDD and OUD, did the reboot translate to real benefits?
Yes, the findings showed a very distinct path for ketamine in this dual diagnosis group. It produced a rapid and substantial drop in anxiety symptoms within hours of getting the infusion.
Hours. Wow.
Yeah, and this was accompanied by a really pronounced decline in opioid cravings too, also very quickly.
So quick relief for both anxiety and craving.
Essentially, yes.
Yeah.
Rapid relief from both depressive and anxiety symptoms, often seen within hours, which you can imagine is a huge advantage if someone's in acute distress.
Absolutely. If someone's really suffering or cravings are intense.
That rapid action could be critical in that moment.
That sounds incredibly impactful,
Yeah.
especially for that acute distress.
Yeah.
But is it just a quick fix? Does that speed mean it's a permanent solution, or are there downsides?
That's a really important question, and it's a crucial point the paper brings up. While the relief is rapid, yes, it's generally short-lived. Typically lasts about a week, maybe, unless you get repeated infusions. And the study does note potential concerns with long-term use. Things like physical or psychological dependence are possible, and chronic use might lead to mood shifts or cognitive issues.
So still lots to learn about the long term.
Definitely. Its long-term consequences, the best way to dose it over time, that's all still under active study. It's a powerful tool, no doubt, but needs careful management. Balancing that rapid relief with sustained well-being is key.
Okay, so if ketamine is the fast-acting disruptor, potentially short-lived, what about buprenorphine? That's kind of the quiet workhorse of addiction treatment, isn't it? How does its strategy compare here?
That's a good way to put it. Buprenorphine is very well known, widely used in medication-assisted treatment, or MACAT, for opioid use disorder.
Right.
It's what's called a partial opioid agonist, so it partly activates opioid receptors in the brain, but not fully.
Okay.
And just like ketamine in this trial, it was used adjunctively, added on to standard treatments for both conditions.
And how does it help with anxiety and cravings? Is it the same mechanism?
No, it's different. Its effects there are mainly through its actions at the mu-opioid receptor. By occupying those receptors, it helps reduce cravings and withdrawal symptoms. That helps people stay abstinent, helps recovery.
Makes sense for OUD, but the anxiety part.
Well, that partial activation might also provide anti-anxiety effects by stabilizing the body's own natural opioid system, the endogenous opioid system.
So bringing balance back?
Kind of, yeah, bringing balance back to that internal system that's been dysregulated by addiction. Think of it like a steady hand, gently stabilizing things, easing cravings and anxiety by restoring that balance over time.
So it's more about stabilizing the opioid system, managing withdrawal, rather than that rapid rewiring we talked about with ketamine. Sounds more foundational maybe for the addiction side.
That's a really good way to describe it. Buprenorphine also interacts with other receptors, like kappa opioid receptors, which contributes to its anti-anxiety effects by modulating stress responses.
Okay.
And a key safety feature is that because it's only a partial agonist, it has a ceiling effect on respiratory depression.
Meaning it's safer than a full opioids.
Much safer in that regard, yes.
Yeah.
It won't shut down breathing in the same way a full opioid could, which makes it a safer option for anxiety relief compared to, say, misusing other opioids.
Yeah.
And the paper suggests this sustained, stable binding to the receptors might be why you see that gradual but sustained reduction in anxiety with buprenorphine. It provides consistent, steady regulation.
And so, unlike ketamine's rapid effects, what did the study show for buprenorphine's timeline? Was it also immediate or different?
It was different. In the study, buprenorphine was linked with a more gradual improvement in anxiety. It sort of evolved over several days, but it was sustained.
Okay, slower but steady.
Right. And that was paralleled by maybe a modest initial drop in craving, but then a more persistent lessening of craving over that week.
Interesting.
And other studies have shown it might help with suicidal thoughts and cravings too, which is really relevant for this group.
Mm-hmm.
However, and this is a key point from the paper, its effectiveness specifically for depression over the long term. That's still largely unknown.
Ah, okay. So it excels at the OUD side, helps anxiety gradually, but the direct long-term hit on depression is less clear compared to ketamine, even if ketamine's effect is short.
That seems to be the picture emerging, yes. Different strengths and weaknesses.
Okay, so we have these two very different mechanisms. One doing this rapid neuroplasticity thing, the other offering more gradual opioid system stabilization. Given these different approaches, how did the researchers actually compare them? What did the trial look like?
Right, so this was designed as a randomized, double-blind, active controlled clinical trial. That's really the gold standard for trying to get robust results and minimize bias.
Go.
They recruited people aged 18 to 65 who had diagnoses of both MDD and OUD. They gathered participants from a hospital, Ibn Sina Hospital in Shiraz, Iran.
Mm-hmm.
And these participants were randomly assigned, like flipping a coin, to get either ketamine or buprenorphine.
And how were they given?
The ketamine group got 0.5 milligrams per kilogram, given intravenously, so through an IV drip over 40 minutes. The buprenorphine group got 16 milligrams sublingually under the tongue as a single dose.
Okay.
And crucially, both of these were given alongside the standard psychiatric and addiction treatments the patients were already receiving.
Right, the adjunctive part.
Exactly. And the researchers wanted to measure changes in anxiety and severity. They used a standard scale called the Hamilton Anxiety Rating Scale, or HAM,
Okay.
and also craving intensity, using the opioid craving scale. They took measurements before the treatment that's baseline, and then again at 2 hours, 24 hours, and 7 days after the intervention.
A week-long snapshot, basically.
Essentially, yes. And to make sure the study had enough people to find real differences if they existed, they calculated they needed about 30 participants per group. They initially randomized 64 people in total.
And what about safety? You're giving powerful compounds. When any issues pop up during the study, it's always important to consider that side.
Absolutely, and they monitored that closely.
Sure.
During the study, 2 patients who received ketamine actually developed something called induction mania.
Oh, okay.
And in the buprenorphine group, one patient had really intolerable GI symptoms, stomach issues, and restlessness after getting a high dose. So those 3 patients had to be withdrawn from the study because of those side effects. It really highlights, the need for careful patient selection and close monitoring when using these treatments. Safety first.
Definitely. So after all that, what did the results actually show when they compared these two very different treatments head-to-head for anxiety and craving? What was the perhaps surprising outcome at that 1-week mark?
Well, the overall conclusion was pretty significant. Both ketamine and buprenorphine showed substantial, statistically significant reductions in anxiety levels and also in opioid craving.
Okay, so both worked compared to baseline.
Yeah. Exactly. Compared to their own starting scores, both groups improved significantly. And this improvement was seen at 2 hours, 24 hours, and still there at the 1-week follow-up for both drugs. So it tells us both treatments are effective at reducing these symptoms in this difficult-to-treat group.
But how did they compare to each other? That was the key question, right?
That was the gay question.
Yeah.
And here's the really surprising part, the main takeaway comparing the two. There were no statistically significant differences between the ketamine group and the buprenorphine group in terms of their effects on the final anxiety scores or the final craving scores at that 7-day point.
Wait, really? So even though ketamine had that super rapid effect and buprenorphine was more gradual, by the end of the week, the final outcome measure, the amount of reduction, was basically the same between the two groups.
Effectively, yes. Statistically speaking, they couldn't find a significant difference in the level of improvement reached by day 7.
Wow. Okay, that is an aha moment.
Yeah.
It's not just about having two tools, it's realizing that different paths or different speeds might lead to a similar place, at least in the short term.
Precisely. It's a very important nuance, isn't it? It implies that while their immediate effects might look quite different, ketamine with that fast, dramatic initial drop and buprenorphine working more slowly but steadily,
Right.
By the end of that week, both adjunctive therapies seem to have achieved comparable overall reductions in anxiety and craving in this specific patient group.
So both hold real promise.
They do. Both seem promising for mitigating these really challenging symptoms in people with both MDD and OUD. It gives clinicians and patients potentially more options.
Yeah, you could almost imagine tailoring it, maybe ketamine for that acute crisis relief.
Potentially, yes. And then maybe transitioning to something like buprenorphine for more sustained stability. It really opens up thinking about more personalized, flexible treatment strategies.
For someone listening, maybe someone grappling with these issues themselves, or they know someone who is, what do these findings mean practically for real-world treatment? How might this change things?
Well, it suggests we might have two valuable additions, or at least adjunctive additions, to the treatment plan for this incredibly challenging group.
Okay.
Knowing that both seem effective at least over a week means the choice between them could potentially be guided more by the patient's immediate needs, right, or the specific clinical situation.
Well, you said rapid relief needed, maybe ketamine.
Perhaps, yes.
Right.
If rapid symptom reduction is the absolute priority, maybe in a crisis, ketamine might be considered. But if a more gradual, sustained approach to stability and craving reduction is the preference, maybe buprenorphine is the choice.
So it moves us towards more personalized care?
I think it does. It allows clinicians to potentially tailor treatment more precisely to the individual.
But, no study is perfect. And this paper, like all good research, pointed out its own limitations, things we need to keep in mind when we think about these results.
Absolutely, and that's critical thinking about any research.
Huh.
Yes, there are several important limitations to consider here.
Like what?
Well, first, the sample size was relatively small, and it was conducted at just one hospital, a single center in Iran.
So generalizability might be an issue?
Exactly. It limits how much we can generalize the findings to, say, broader populations, different healthcare systems. Also, women were notably underrepresented in the study sample.
Okay.
And crucially, the follow-up was very short-term, only 7 days. So we don't know from this study about the long-term effects. Does the improvement last? Do side effects emerge later? We don't know.
Right. A week is just a snapshot.
A very short snapshot.
Yeah.
And perhaps the most significant limitation, especially for interpreting causality, is that there wasn't a control group that only got standard care.
No placebo or standard care only group.
Correct. No group got just the standard psychiatric and addiction treatment without either ketamine or buprenorphine added on.
So we can't be absolutely certain the improvement was only due to the ketamine or buprenorphine.
We can't be 100% certain based on this study alone. It's possible that standard treatment itself, or maybe just the extra attention of being in a trial or other factors, played a role in the improvement seen in both groups.
Okay, that's a really important caveat.
It is. Future research really needs to tackle these things. We need larger, more diverse samples, definitely longer follow-up periods, weeks, months, and ideally, studies that include proper control groups, like placebo or standard care only. That would make the findings much more robust and generalizable.
So it points the way, but more research needed.
Always the case in science, right? But it's a very promising direction.
So let's recap. We've explored how ketamine and buprenorphine, two really different compounds, different ways of working, both show promise as add-on therapies for anxiety and craving for people facing that tough dual challenge of major depression and opioid use disorder. They might reach a similar destination, symptom reduction over a week, but they seem to take different paths. One offers that really rapid relief, the other a more sustained gradual improvement.
A good summary, yeah. Different timelines, potentially similar short-term outcomes.
This whole conversation, it really highlights the ongoing search, doesn't it, for more personalized, more effective treatments for these complex mental health conditions.
Absolutely. We're constantly looking for better ways.
And it makes you think, doesn't it? As research keeps uncovering these sort of nuanced pathways, how might future treatments be tailored even more precisely to fit the individual's needs, their symptom patterns, moving beyond just a one-size-fits-all approach?
That's the hope. Personalized medicine for mental health.
Could we even see treatment plans that maybe fluidly switch between approaches, optimized for the acute crisis and for long-term stability?
It's certainly something researchers and clinicians are thinking about. How to best sequence or combine treatments for the best overall outcome. Fascinating possibilities.
Well, thank you for joining us for this really insightful exploration today.
My pleasure.
And thanks to all of you for listening. Until next time, keep learning and stay curious.